Welcome to Procure en Parle. Good evening, ladies and gentlemen. For those who are joining us for the first time, Procure is a not-for-profit organization like the Canadian Cancer Society, except that we are, excuse me, something is actually obstructing the view here, except we are entirely dedicated to prostate cancer. And since information is the first remedy, Procure offers a monthly webinar on various topics to learn all about this disease, which affects 12 men every day in Quebec. Now, today we will be discussing the role and effects of hormone therapy on prostate cancer with Dr. Danielle Lewinshtein, Chief Division of Urologic Surgery, Laparoscopic and Oncologic Surgery at the Hospital Center Pierre-Boucher, and also Assistant Clinical Professor at the University of Sherbrooke. Thank you so much, Dr. Lewinshtein, for accepting our invitation tonight. Thank you. We will have a presentation by our specialists, followed by a question period. Speaking of question, thanks for those that we received in advance. Otherwise, you can submit them using the QA button at the bottom of your screen, and they will be read during the question period. Now, before starting, we would like to thank all of our donors from the bottom of our hearts. And this webinar is presented by Industrial Alliance and our partners, the Association des Urologues du Québec, Astellas and Bayer Laboratories, which, among others, are involved in the treatment of more aggressive and advanced prostate cancer. Thank you so very much for your support. It's really appreciated. Now, this is going to be a great webinar. There's a lot of questions, there's a lot of material. So without any further delay, I'm turning the floor to you, Dr. Lewinshtein, and you can certainly share your screen.
Perfect, thank you.
Thank you.
Okay, is it clear? So I'm going to be talking to you about all the effects of hormone therapy. And I'm sure a large number of you have already been exposed to hormone therapy. Others haven't and may want to know about it because at some point you may be exposed to it. So we'll be going over the basics of hormone therapy and its effects on your body and some of the tools we can use to mitigate side effects of different types of hormone therapy. So as Marie-Christine said, I'm a urologist at Département d'Urologie Pierre-Boucher, and I've been there for the last 6 years, and I did a fellowship in urologic oncology about 10 years ago in Seattle, Washington. So just a brief overview. First of all, we'll talk about the Gleason score and the stages, as well as a little bit about PSA. We'll discuss the treatment options that do include hormone therapy and how they are included with those treatments. As well, we'll briefly go over the different types of hormone therapy, as well as what happens when the PSA is going up when you are on hormone therapy. Then we'll speak a little bit about side effects, what you can do as a patient to prevent the side effects of hormone therapy, and then just specific goals, tips, and advice that Procure has actually developed for you, the patients, to try and avoid and try and mitigate any side effects that may occur with different types of hormone therapy. And then, as Marie-Christine said, at the end, a period of questions, and I'm open and I'm available all evening as need be. So just as a disclosure, I have no conflict of interest with respect to this subject at all. So the basics of stage, grade, PSA, and how do those things affect your risk of recurrence when you have prostate cancer, and your risk of progression when you're diagnosed with a new diagnosis of prostate cancer. So first of all, stage. So what is stage? So stage basically tells you the extent, the local extent, as well as the extent at a distance of your cancer, and that could be any type of cancer. In this case, obviously, we're talking about prostate cancer. So when we see a patient as a urologist, we do a digital rectal exam. So we want to know, do we feel a lesion? So when we do the digital rectal exam on the patient and we feel a little bump, it's at least what we call a clinical T2. So a clinical T1 would be a patient that has an elevated PSA, got a biopsy, had a confirmed diagnosis of prostate cancer. However, we could not palpate that lesion on digital rectal exam. And that may be because the lesion is too small, or because that lesion is not in the posterior aspect of the prostate. So it's not in contact with the rectum, so we don't feel it necessarily. Patients, as I said, that have a lesion will be at least T2. Now, if we feel that bump is almost pushing a little bit through the rectal wall, we feel it quite closely, we would call it a clinical T3. And then if we felt that the prostate was fixed, so ideally when we did our digital rectal exam and the prostate didn't move at all when our finger was in the rectum, we call it a T4, so that's invading adjacent structures. And obviously T4 is worse than T3, T3 is worse than T2, and T2 is worse than T1. And then of course, if you do have prostate cancer, that disease can as well go to the lymph nodes, which is what we call N1. And it can also go to distant organs, specifically, most commonly, the bone, which is what we call M1. That being said, more and more, we're imaging patients to more extensively. We're including more chest scans, and we're finding more and more patients that are known to be metastatic to have lesions in other places that weren't classically thought of to be associated with prostate cancer. So the second aspect, the second way that we evaluate prostate cancer is its aggressiveness, its biological aggressivity, and that we can talk about grade. And the grade is basically the Gleason score. So the Gleason score, which was invented by a pathologist called Dr. Gleason back in the 70s, used to start from 6 and it would go up to 10. So 6 being the least aggressive and 10 being the most aggressive. We consider Gleason 6 to be what we call low risk, Gleason 7 to be what we call intermediate risk, and Gleason 8 and higher to be called high risk. More recently, about 3 years ago now, these were refined and they were called now Gleason group grades 1 through 5. And again, Gleason group grade 1, which represents Gleason score 6, is considered not aggressive. Those are patients that we typically do not treat in 2021. We follow those patients irrespective of the number of cores of prostate cancer they may have. Gleason group grade 2 is what we call favorable intermediate risk, and those patients we're actually starting to follow as well. So we don't treat all those patients. We used to treat all group grade 2s. We don't now. Group grade 3 and more. Group grade 3 is what we call unfavorable intermediate risk, and those we treat unless patients are very comorbid, very sick, or the patient and the family does not want treatment. And in group grade 4 and 5 are what we call high risk meaning more risk of progression, more risk of recurrence after treatment, more risk of finding metastases on imaging studies, either on the initial imaging studies or in subsequent follow-up to treatment. And if you see here, there's a little picture on the right side. I don't know if you can see this, but essentially as the prostate cancer gets more aggressive, it goes from being these nice round glands to being more of a paper of cells. So as it becomes more aggressive, it becomes more cellular and less gland-like. The other thing we talk about, so we said we talked about stage, we talked about Gleason score, is the PSA. So we see a patient up front. Initially, we look at those two other evaluators, and then we look at PSA. So a patient that has an initial PSA at first time of visit or just before biopsy of 0 to about 10, we consider that low risk with respect to their PSA. Now, they may have a biologic high-risk cancer, a Gleason 8, occult on biopsy, but with respect to the PSA, we call that patient low risk. Now, if the PSA is between 10 and 20, with respect to PSA, they'd be called intermediate risk. And if the PSA is higher than 20, they'd be a high-risk patient based on PSA, which means a high risk of recurrence and also a higher risk of finding metastases at initial imaging studies. So what are the studies that we can use to measure extent of prostate cancer? So of course, we looked at PSA, we looked at Gleason, we looked at stage, and those are the things we'd use to decide whether the patient needs a biopsy, classically, as well. If we had a diagnosis of prostate cancer, and depending on the aggressivity, then we decide whether the patient may or may not need tests to look for metastases either to the lymph nodes or to the bone or to other organs, including lung and sometimes liver, rarely. So if a patient walked into my office and had high-risk disease, I would ask for a CT abdomen and pelvis. I would also ask for a bone scan. And the CT abdomen and pelvis is to look mainly for lymph nodes and can also see bone lesions when they are more prominent. And then bone scan is specifically to look at lesions that have metastasized from the primary prostate cancer. And then as well, there is MRI. MRI is mostly used actually in the pre-biopsy setting by urologists, in the sense that more and more we're using MRI to risk stratify patients to decide whether or not they may need a biopsy or not. It can also be used, though, by the radiation oncologist and certain surgical centers as well in the US, not so much in Canada, to look at surgical planning. So i.e. A patient that has a specific risk profile, do they possibly have extension of the disease outside of the prostate? And if so, how is that going to change treatment? So for instance, a patient that has a high-risk prostate cancer, let's say a Gleason 8, a PSA of 20, and we're going to operate that patient, and the patient has disease on one side on biopsy, and MRI may help to see if there's possible invasion of the nerve bundles. And we know that those nerve bundles are important for erectile function. So if we were to see, for instance, that on MRI there was a risk of the nerve bundle being affected, we may not consider doing a nerve-sparing procedure on that side. In addition to that, the radiation oncologists also use MRI specifically in their planning for radiation treatment, as well as for brachytherapy treatment. So when exactly are hormones used? So specifically, as I said before, low-risk disease, we don't treat those patients. There's really no centers in Canada that treat low-risk disease unless the patient is really quite anxious. And even with that, we'd only treat high volume, low risk. So in intermediate risk, when do we use it? We do not use hormones for favorable intermediate risk, which is the low risk Gleason 7. Radical surgery, so if I was to do a prostatectomy, we do not use any hormones at all. There were interesting trials done, mostly in Canada, actually, about 15 years ago, looking at the utility of perioperative, either before surgery or after surgery, hormonal use. And it was shown to change pathological outcomes, so i.e. the look of the cancer on the biopsy that we removed the prostate. However, it did not change survival or rates of progression to metastases after surgery. And so it was never further used as an adjunct to surgery. That being said, trials in the radiation oncology field that were done about 10 to 15 years ago now by Bola showed clearly patients that were receiving radiation and or brachytherapy for unfavorable intermediate risk benefited from a short-term hormone course, usually 4 to 6 months of hormones, which is given in the time period starting just before radiation treatment, and then usually subsequently for another 4 to 6 months. And this was shown to decrease the risk of PSA recurrence. And more importantly, it was also shown to increase survival and has become standard of care for patients receiving radiation. The goal, of course, in unfavorable intermediate risk patients is curative. And that is the utility of the hormones to help in the cure of those patients. In patients with high-risk disease, so is it ever used in surgery? As I said before, we don't use it before surgery in what we call it neoadjuvant. We don't use it in the post-operative period in a patient that has a descent of PSA. That being said, if I was to do a prostatectomy and we would do a lymph node dissection, so we would remove the lymph nodes in the pelvic area that drain the prostate in a patient with a high-risk disease. And if, for instance, those lymph nodes were found to be positive for prostate cancer to them by the pathologist, there would be a discussion with the patient. And the most powerful trial to date has shown that there is a survival benefit for patients with lymph node disease found during surgery to receive hormone therapy. So that patient would be canceled, that they would derive benefit from hormones, and that would be a discussion with the patient, with urologist, as to whether it was to be done or not. As well, a patient that did have radical surgery that had a non-descent of PSA, so a patient that had a PSA of 8 or 10, had surgery and then the PSA did not come down and they were deemed to have what we call persistent disease, they would receive radiation to the prostate bed in and around where the bladder would be. Those patients would also receive hormone therapy. As well, patients that had high-risk disease were operated on and had recurrence with the PSA coming back. And those patients, they would receive radiation. They would also now receive, for the last couple of years, what we call concomitant or hormone therapy at the same time as them receiving this salvage radiotherapy. In addition, patients that receive external beam radiation and or brachytherapy for high-risk disease receive long-term hormone therapy. So classically, these patients received approximately 3 years of hormone therapy, and now some would have side effects and would possibly stop it beforehand. However, there was an interesting trial actually done here in Quebec about 7 years ago now that showed that patients that had radiation therapy for high-risk disease and were supposed to receive 3 years of hormone therapy, they actually had similar survival outcomes and similar biochemical recurrence outcomes if they only received 1.5 years of hormone therapy instead of the total 3 years. So standard of care in most centers treating with radiation therapy for high-risk disease in Quebec is to give 1.5 years of hormone therapy. And that helps patients with respect to the side effect profile as well. The duration being shorter, the bounce back of testosterone production is faster. So again, as I just mentioned, patients with recurrence without metastases would receive hormone therapy now in 2021 with salvage radiation to control those patients. And those patients, actually some can have full cure even if they did have recurrence after. So it's not just control. So what about patients that are metastatic? So metastatic means that the prostate cancer that started in the prostate has gone to other areas. So i.e. the bone, the lymph nodes that are not in the pelvis, though the low pelvis region near the prostate, or could be in the hormones high up in the abdomen or up in the chest area. So all patients that had metastatic prostate cancer would receive hormone therapy. Some of them now, for the last 1.5 years, 2 years now, can receive upfront what we call advanced hormone therapy. So different agents that either help to block the production of testosterone or block the interaction of testosterone with its receptor. And this is a new indication classically for the last about 80 years, since the time of Huggins, who was a Canadian scientist that discovered the utility of hormone therapy. There wasn't a lot of new discoveries, but this new discovery of this new advanced hormone therapy helps to protect patients from progressing and helps to prevent development of metastases. As well, patients that are metastatic can benefit from chemotherapy if they have a large burden of metastases. So we consider that a patient that has 4 or more metastatic sites, so 4 different sites on bone, or for instance, what we call visceral metastases, which is disease to the organs of the abdomen, i.e. the liver, or organs in the chest, i.e. the lung. Those patients can benefit from chemotherapy and have large increases in their survival time. As well, patients that are metastatic can receive local radiation to the prostate, even when they have metastases. These patients, in addition to their hormone therapy, have now been shown to derive benefit locally from radiation, even when they have metastatic disease, if And the caveat is only if they have a low volume metastatic disease, so not a lot of metastatic sites, so i.e. 4 or less. As well, a new treatment that is coming on board in prostate cancer the last couple of years is to treat patients that have either low volume metastases or specific metastases that are painful with stereotactic or SBRT radiation. And this is giving high dose radiation to very focal sites with very little collateral damage to tissue adjacent. And this radiation can not only palliate symptoms, but in some cases can prevent progression in patients that would otherwise only be treated with hormone therapy. And of course, there are always more and more treatments and more clinical trials going on. As we know, prostate cancer is the most common cancer in men, in both in Canada and in the USA. And mortality from prostate cancer is only second highest to the lung due to the overall burden of prostate cancer on society in Canada. So a lot of money goes into research, both in Canada and in the United States, into different molecules, different treatments. And so the treatment field, the paradigm is constantly evolving all the time. So the different types of hormone therapy. So there are 3 main types of hormone therapy for prostate cancer. The main type are what we call LHRH agonists. And these are injections or implants that can be given by a nurse or a physician, which essentially stop the production of testosterone. And the new one on the block is called Firmagon or Dagarelix, which has been around for about 10 years now, which works a little bit differently. And it doesn't, it blocks the production of testosterone, but a different way. It blocks the interaction with LHRH, which is secreted by the brain. Whereas the classic hormonal treatments that we always talk about actually stop the production of LHRH at the level of the brain. And secondly, there are also oral tablets, which are the new generation, what we call anti-testosterone medications, which are tablets that block the effects or the ability of testosterone to either be produced or to interact with its receptor at the cellular level. And then finally, we can also stop testosterone production by removing the testicles, and that is called orchiectomy. It was a procedure that was commonly done in the past, rarely done these days for a couple of reasons. One is with the introduction of commonly available hormonal therapies over the last about 30 to 40 years, patients don't aesthetically want to have their testicles removed. B, the other issue is that when the testicles are removed, obviously you can no longer have testosterone production, so you cannot reverse what is done. However, when patients receive hormonal treatment, LHRH or LHRH antagonists, those treatments can be reversed by stopping the treatment. Now, if the treatment is taken for a short duration, testosterone production can come back. However, if these treatments are taken for a long time, then testosterone production sometimes may never come back. And that has to be explained to the patient. So what are the standard hormone therapies? As I said, the classic, what we call the LHRH agonist, which is preventing the production ultimately of LHRH from the brain, from the hypothalamus. We have Leuprolide, which is sold commercially as Lupron or Eligard. We have Goserelin, which is sold commercially as Zoladex. And we have Triptorelin, which is sold commercially as Trelstar. And these agents are all quite similar. They are sold by different commercial entities. And their goal is to ultimately stop testosterone production by the testicles, which produce about 98% of the testosterone in the body. There's about another 2% that is produced by the adrenals, which is not stopped by the classic LHRH agonists. In addition, as I said before, There are the LHRH antagonists, and there is only one commercially available now, which is an injection, Dagarelix, or commercially called Firmagon. It works a little differently than the classic ones in the sense that it interacts with the LHRH molecule and prevents it from further producing testosterone at the level of the testicle. The slight differences between Firmagon and the others: Firmagon is only given as a once-a-month injection, as opposed to the other ones, which can be given once a month, once every 3 months, or once every 6 months. And obviously for patients, treatment that can be given a little less often may be more convenient for the patient. As well, Firmagon does have more local symptoms when getting injection. Patients sometimes complain of a little bit more pain at the injection site, as well as more inflammation at the injection site. However, there are some possible benefits of Firmagon. There may possibly be less cardiovascular events in patients taking Firmagon than in the classic LHRH agonist, but that is to be further studied. And as I said before, the new not the new molecules, but the last one is called an anti-androgen. The most commonly used is Castrate-Resistant, and this is most commonly used in addition to the classic agonists when we are first starting therapy. It is very rarely used as monotherapy for the inhibition of testosterone production. So as I said before, how is it injected? It's injected every month, every 3 or 4 or 6 months, intermittently if PSA levels are stable, and sometimes it will be given for life if the patient had an advanced cancer. And as I repeat, in patients that are first starting on the classic agonists and who do have metastatic disease, we give them Castrate-Resistant for the first 2 to 4 weeks to prevent what we call the testosterone flare that does occur when we initially start the classic agents, which can cause a flare-up of pain or other complications at the level of the spine. So what are the goals of hormone therapy? So obviously the main goal is to prevent your body from making testosterone. And then the second goal is from stopping the cancer from either growing or spreading. So used alone, hormone therapy will not cure your prostate cancer. What I tell patients is it slows it down, but it can be very efficient at slowing it down. It is, however, an effective treatment to reduce the size of a tumor before radiation. So as I said previously, before radiation therapy for high intermediate risk disease, you will receive hormone therapy, which will reduce the size, which will increase your benefit from treatment. It can also increase the effectiveness of radiation therapy, as we said before. It can control progression of remaining cancer cells after treatment. As well, it can treat prostate cancer that is advanced or that may come back after initial treatment, such as surgery or radiation. And finally, as we know, one of the interesting things about hormone therapy is that it can come into contact with prostate cancer cells anywhere in the body, whether they be in the prostate bed, in the lymph nodes, in bone, or any other metastatic site, for the most part, until the hormonal manipulation may not become effective anymore. So what happens when you are on hormone therapy and your PSA starts going up? What does this signify, and what is there to be done with this clinical entity? So as we know, hormone therapy will prevent the progression of prostate cancer for several years. If your PSA is low and is not progressing, in general, that means that your cancer is under good control. There are very rare types of prostate cancer that either we know up front or what we call neuroendocrines who do not produce PSA. And sometimes in rare cases, prostate cancers that are classic, what we call adenocarcinomas, can transform to different, more aggressive subtypes where PSA may not rise, but where we do find progression on either bone scan or on CT scan. And that would be up to the choice of the treating physician to decide at what interval you may need scanning either bone or CT abdo-pelvis thorax. However, in some patients, the PSA will start to go up and the hormonal therapy may be less effective. Sometimes the PSA can go up rapidly. And when this happens, we measure how fast the PSA is going up. And of course, we measure testosterone. So if your testosterone is blocked, i.e. you have a low testosterone level under about 0.7 nanomolars per liter, and your PSA is rising, and the classic definition is 2 rises with a blocked testosterone, we consider that castrate-resistant or hormone-resistant. And if that's the case, patients may require a new generation hormonal agent or a manipulation, or they may require chemotherapy, and that depends on the specific clinical situation as well as the discussion between the physician and the patient and the family. So what are these new generation hormone therapies? The approved molecules that are available now in Canada, we have enzalutamide, we have enzalutamide, so just to explain, enzalutamide, apalutamide, and darolutamide all inhibit the ability of testosterone to interact with its receptor. So testosterone is still produced in its presence. However, it cannot interact at the cellular level and give what we call oil to the prostate cancer cells to reproduce and to increase in size and to send cells to other areas of the body to cause metastases. Abiraterone works a little bit differently than the 3 other not classical, but the 3 other agents, in the sense that abiraterone inhibits the ability of cells to produce testosterone. And as I said, the majority of testosterone production is at the level of the testicle. However, about 2% is in the adrenal gland, as well as in patients that have advanced prostate cancer. Sadly, what occurs is the prostate cancer cells themselves acquire the ability to actually produce testosterone on their own, irrespective of the body cells, and abiraterone can actually interact with those cells and prevent testosterone production by those cells. So when are these used? So it depends on the clinical entity. So patients that are initially metastatic, we now use these agents in those patients, even if they're upfront. In addition to classic hormonal manipulation, we may add on one of these new approved molecules, and this is shown to reduce the progression to metastases, as well as increase overall survival. Classically, patients that were upfront metastatic were put on hormones about 30 years ago, had a lifespan of around 6-7 years. Now with these manipulators, we can increase these for 10 years and longer, as well as patients that are on hormonal manipulation and become resistant to hormonal manipulation, i.e. their PSA is rising despite a negative testosterone, and those patients have metastases on imaging. We can add on one of these agents. And even if they don't have metastases on imaging, which we call non-metastatic CRPC or non-metastatic castrate-resistant prostate cancer, these patients now also, we know, benefit from recent trials from adding on one of these new approved molecules. So as I said on the last slide, their mechanism, they either block the activity such as abiraterone, or they may block the production of, they either block the activity with such as enzalutamide, or they block the production of testosterone as abiraterone. And what are the advantages of these agents? One of them is that they're all taken orally, so the patient does not have to come to the hospital. They don't have as strong and as durable side effects as classic chemotherapy. The classic chemotherapy in the realm of prostate cancer is a docetaxel, or what is commercially called taxotere, which has a stronger risk profile, more side effects than these new agents. As well, it has been shown to delay progression to the bones, so that is important for pain control, as well as for fracture risk. And patients that have fractures to the spinal column are at risk for other complications such as neurologic compression, i.e. causing pain, or sometimes even in severe cases, causing bowel and bladder dysfunction. As well, it has been shown to increase the delay to chemotherapy. So patients that were otherwise would have received chemotherapy for high burden metastatic disease can then be delayed, so they have a better quality of life. And so those patients may be able to spend more time doing whatever activities they like doing and spending more time with friends and loved ones. And finally, as I said before, this new generation of hormonal blockers or manipulators has been shown to increase overall survival, which is what is classically considered the most important outcome of interest in oncology studies. So what exactly, I think this is the most important part of the talk tonight, and this is what affects you, the patient. What exactly are the side effects of these different agents, and how can we mitigate them? So the side effects depend on a couple things. One is how long you're taking the molecule. So if you're just taking a hormonal agent for 2 to 3, 4 months, you're going to get your testosterone production back. However, if you are on it for years, and that really depends on each patient, patients that have underlying metabolic syndrome, diabetes, hypercholesterolemia, high blood pressure, and they're on these agents for a number of years, more than 3, 4, 5 years, they sometimes either get partial production of testosterone back or no production of testosterone back. And it really is patient dependent. And it's also dependent on your age. And as I said, your overall treatment and duration. So what are the exact side effects? So, you know, the main, not to say the most important, but the one that is strongest, almost all patients will lose their libido. So that doesn't necessarily imply erectile dysfunction, so the mechanical aspect of getting an erection, but about 90% of patients will lose the desire to have sexual intercourse or in sex in general. And that is due obviously to the loss of testosterone production. And we know that it is testosterone that gives men that desire to have sexual relations. It also is going to cause erectile dysfunction in a large proportion of patients due to loss of desire, but also due to mechanical changes. As well, patients do report penile shortening of approximately 1 to 2 centimeters in multiple trials. As well, a lot of patients will get hot flashes. And in some patients, these are not very strong, and in others, these are stronger. And these can be brought on by no specific triggers. In other patients, they classically have triggers such as alcohol, smoking, stress, hot weather. Sometimes if they're wearing tight clothing, sometimes specific spicy foods may bring it on. As well, patients report fatigue, and we know patients that have low testosterone are going to have fatigue, and these patients have absent testosterone, so we expect them to have fatigue. As well, about 7 to 10% of patients are going to have a weight gain, and about a couple percent of patients are going to have muscle loss. So sorry, I in error, I said not a couple percentage, but most patients are going to have on average about a 7% increase in weight gain. And the median patient is going to have about a 2% in what we call lean body mass, so the presence of muscle in the body. As well, this is one of the most important complications is the weakening of the bones from the loss of testosterone and the subsequent fracture risk. So we know from large trials that patients that are on hormones, their risk of fracture over a 5-year period is about 19% compared to age-matched controls not on hormonal manipulation to about 13%. That may not seem like a lot, but it's actually about a 40–50% relative increase in fracture risk, and these can be important. As well, there can be mood changes and possible cognitive changes. We don't know whether this is due, it's not clear whether this is due to the medication itself or whether this is due to the fact that patients that have prostate cancer are obviously older, and as patients age, they are going to have cognitive decline. This remains to be elucidated. There's also a risk about 20% of patients that are on hormonal therapy are going to get or begin to have diabetes. Lipid levels are going to change, and a certain percentage of patients are going to repeat increases in blood pressure. And the last point is there is most likely an increase in cardiovascular events. This remains to be have consensus. Multiple trials have showed increases in cardiovascular disease, which makes sense due to changes in metabolic profiles. Other trials have shown no increase in cardiovascular disease. This remains to be seen. There have not been any large randomized clinical trials that have done yet to give conclusive evidence as to this point. So as I said on the prior slide, things that you may notice: weight gain, decreases in muscle mass, and this may be evident, changes in your blood sugar levels if you don't have diabetes, or if you do, your family physician or your urologist who may draw cholesterol or lipid levels may notice increases in your lipid levels. And as well, you or your physician may notice changes in your blood pressure with the utility of hormone therapy. And as I said on the prior slide, these may contribute to your overall risk of cardiovascular disease. So what can exacerbate these side effects? So patients that are fatigued, either because of loss of testosterone, because the patients aren't getting good sleep, a poor diet. So patients that eat a diet that is rich in fat, rich in salt, rich in sugar, these will exacerbate these side effects. Patients that are under stress, we all know how hard stress can be on the body. And one of the most important things is obviously we say it can be done. That's another thing, is to try to mitigate stress to derive the most benefit from treatment. And lastly, the consumption of alcohol and tobacco has also been shown to worsen the side effects of hormone therapy. So what is your role? I think this is the most important. What is your role as the patient? What can you do to try and prevent these side effects? So I think it's important with your urologist or with your family doctor to discuss the different hormone therapies that are available. How can duration affect your side effects? What are the long-term side effects, such as cardiovascular disease? You should also tell either your internal medicine physician or your family doctor, and they should also know that you are now on a hormonal agent, and they should be aware of these possible changes that are occurring or may occur in the near future. You should also pose hard questions to the urologist or the radiation oncologist or the oncologist as to whether these recommended treatments are going to affect your current diseases and whether the risk-benefit analysis has been done. Ask as well if you could possibly go on intermittent hormone therapy if your PSA is unstable, and that is really only in specific clinical scenarios. So, as I said priorly, really discuss these things. You are your best advocate. Make sure you have a family doctor. Make sure if you do have one that they're aware of what's going on, and make sure that you have your annual checkup. And I know it's very hard to get a family physician in Quebec, but we should all try our hardest to have one that follows us along with our specialist. So what you can do. So probably the number one thing is physical exercise. Quebec doesn't have specific recommendations on this, but Cancer Care Ontario has done multiple trials and has shown, not just specific for prostate cancer, but patients doing 150 minutes per week of moderate intensity exercise. And this is ideally to be split among 3 to 5 sessions, in addition to strength training, which specifically has been shown to prevent bone issues, can help immensely in preventing side effects of the prostate cancer treatment. One of the easiest things that you can do is just go out for a walk. It's free, it's easy to start doing, and you can start it any day of the week that you want to. So as I said, multiple prospective trials, large trials in oncology, patients have shown that if you do exercise, you're going to have an improvement, and you're going to have an increase in your ability to do more exercise. You're going to have better cholesterol levels. You're going to have a likely risk reduction in your risk of heart attack, your risk of stroke, your risk of having clots in your veins or in your arteries. It's also been shown to decrease your overall mortality in specific trials. It's going to decrease your risk of either having progression of your diabetes or having new onset diabetes with new hormonal manipulation. And finally, results that you can see is that it will help with weight gain and obesity. You will most likely get an increase in your strength and muscle mass, increase in self-esteem, Sleep should improve, and concentration and cognitive function has also been shown to improve with exercise. So the second main thing is diet. So as we said, the first thing is exercise. The second aspect of you as a patient is diet. So really the main thing is try to avoid high fat, high sugar diets. And the other thing is not necessarily to follow a new fad diet such as high protein diets, but really follow the Canadian food guidelines and everything in moderation. And if you don't know exactly what to eat, obviously you can go on any reputable website and look up these different types of diets or different types of diet profile, as well as looking for the help of a nutritionist. They're professionals and they can give you very straightforward, basic plans, which one can follow, which can also be very commercially viable to help reduce weight gain and prevent diabetes. The last thing that you as a patient can do if you do smoke is to not smoke, obviously, and that is easier said than done. But there are different therapies and adjuncts that are available to try and prevent smoking. And the other thing that a lot of people may not know, but even if you do not smoke, but you are in the presence of smokers, or someone that smokes in your house, is exactly as if you are smoking yourself. So try and avoid those situations. So what should I do, or what should your family doctor do? So the first thing is, if we were to put you on hormone therapy, we should be taking a history for prior cardiovascular disease. As I said, patients that have prior cardiovascular disease most likely have more risk of having a cardiovascular event on hormonal therapy. And we may or may not consider either starting them on agent, depending on their clinical scenario. And we may or may not decide on using a different type of hormonal manipulator to try and reduce the risk of cardiovascular disease. As well, patients that have known cognitive decline, we may explain to the family or to the caregiver and to the patient themselves that they may have a possible cognitive decline, and that that patient should be monitored either by the loved one or the friend or the family physician for a possible change in their mental functioning with new treatment. On exam, all patients in Canada, this is standard guidelines, and this was just put out actually this month, 2021, by the Canadian Urologic Association, that all patients that start hormone therapy should have their blood pressure taken, their BMI taken, their waist circumference taken, and their weight taken. And these things should be followed approximately once a year to make sure that there are no significant changes that need to be dealt with. As well, all patients that are starting on hormone therapy need to have a lipid test, so your triglycerides and your cholesterol levels, your glucose levels, your HbA1c, and these are all at the baseline, as well as a calcium level, as well as a vitamin D level. And the last two are patients that have very low levels, that may have very low levels of calcium, may benefit from higher levels of calcium that we do give to all prostate cancer patients on hormone therapy, as well as they may sometimes benefit from different agents such as bisphosphonates, which can prevent bone breakdown. And to the point I just alluded to, all patients that are starting on hormone therapy should have an upfront bone densitometry scan, which is essentially a scan that looks at the density or the strength of your bone. And there's different scoring systems that are used that look whether patients either have mildly reduced bone density, which we call osteopenia, and patients that have more significant or more severe bone density loss, we call that osteoporosis. And those patients, either osteopenic, need obviously follow up with more bone densitometry at specific intervals. And clearly patients that are osteoporotic, that are not on a bone agent, would need one to prevent more bone loss, specifically due to prostate cancer itself and the effect of the prostate cancer hormone therapy on the bone. So what do we do and what should we give? So we give all patients, as I said, upfront to receive hormone therapy, calcium and vitamin D. We would consider intermittent therapy in specific situations, mainly patients that have had recurrence after radiation or prostate cancer surgery and do not have metastatic disease on imaging. We could consider those patients for what we call intermittent androgen deprivation. and that with the patient understanding the risks and benefits of that clinical decision. As I said prior, patients with cardiovascular disease, we may consider putting them on dagarelix as opposed to a classic LHRH agonist if cardiac history. Bisphosphonates if the patient is osteopenic or osteoporotic, which can be managed by the family physician. And finally, patients that complain of not a loss of desire, but a loss of erectile function would benefit as any patient from Viagra. And some patients, even with little desire, may be able to get erections. It's the minority, but it sometimes can work, and it should be offered to patients that would like it, that do not have severe cardiac disease. Just a little adjunct on hot flashes. So as I said, hot flashes essentially patients that are on hormone therapy, about 80% of them will get them, but the majority aren't severe, but some are. And essentially it's just a flushing of your face. So the blood vessels on the face are flushing. It's exactly like a hot flash in a female. There's a large blood flow to the face, and patients feel a sensation of heat, severe sudden onset heat. As I said before, avoid triggers. Consider using intermittent LHRH, and consider we can give patients a progestin manipulator, which can reduce hot flashes with 80% efficacy. Finally, there are other treatments such as gabapentin and acupuncture, which also have been shown to be effective. So a couple goals from ProCure to you, the patients. I'll end with this. There are tips and advice fact sheets that are available. You can download them from ProCure's website. You can use them with family, with yourself, and try and pick just one goal at a time, one step at a time, and work towards that goal. Ultimately, as I said before, you should speak to your physician about ideal weight goals. With respect to BMI, with respect to exercise. Exercise could be walking, it could be swimming, it could be biking, it could be anything that gets your heart moving to a moderate level. You may want to join a gym and do different types of activities. Definitely harder to do now during COVID, but hopefully that will be coming back soon. And I think that may be the end of the presentation. Am I correct, Marie-Christine?
No, it's not quite the end.
Oh, okay, sorry, I wasn't going for it. Okay, sorry. So with respect to diet, as I said before, many physicians recommend favoring a Mediterranean diet, integrating a diet rich in fruits, vegetables, whole grain products, and specifically low in saturated fats. And I repeat, limiting alcohol and taking the vitamin D and calcium that your provider has prescribed to you. Again, I repeat, very, very important, not just for prostate cancer, but for all patients. And we should all be aware of this as a physician, of smoking and its deleterious effects on health. Specifically causing lung cancer, as most patients know, but most patients do not know that it causes. A lot of patients know that it does not cause. Do not know that it causes bladder cancer and throat cancer. So really, not good for anything. And as well, stress reduction in any way possible with respect to using stress management workshops, speaking to friends, family, psychologists, anything that can help you relax, and especially adhering to a schedule of doing things that you enjoy doing that you know will help you relax and will help you manage your prostate cancer and help you manage the side effects of your prostate cancer treatments. Again, we spoke about blood pressure and cholesterol levels. These are all things that you can do in conjunction with your physician. And those that do take their own blood pressure know that there are specific values that you should try to be within. Cholesterol, same game. If your cholesterol levels are high, then your family physician will prescribe you with an agent that will reduce your calcium levels. And again, I repeat, blood sugar levels should be maintained at normal levels, and these are goals that are achieved in conjunction with either your family physician, your endocrinologist, or your internist. I think we spoke about cardiovascular disease already, and that is just basically the consequence of untreated metabolic changes, your blood pressure, your sugar levels, and your lipid and cholesterol levels. So I think that's the end. Just remember the main points. Speak to your urologist, speak to your radiation oncologist. The one thing I always tell my own family is, the health system is vast. You are your best advocate. When a patient comes into my office and they have all their medications with them and they have all their prior history and all their prior interventions and they know what's going on, they have their questions written down, that helps immensely me treat them properly. Sometimes they may think that we have access to all the information. We do have access to a lot of the information in 2021. We sometimes may not have access to things such as pathology reports. We may not have access to things such as physician notes that were done outside of the realm of our system. So a patient that is well prepared, that has their prior results with them, that has their prior treatment history with them, will immensely help us and immensely help them to get them a better treatment ultimately. Thank you very much for listening to a long presentation without any interaction, and any questions now I am available to answer.
Thank you so much, Dr. Lewinshtein. As a matter of fact, this is such a great presentation. We'll make it available for those who wish to have a copy of it. Now, you've answered most of the questions that we received. As a matter of fact, we received a lot of questions in advance to this webinar, and most of them have been answered. There are perhaps two pending. One of them is, it's a man, he says, I've had 3 shots of hormone therapy, and a year later, I'm still feeling the side effects of hot flashes. How long do the side effects actually last once you end your treatment?
So it depends on the testosterone recovery. So a patient that's on hormonal manipulation for a short duration, let's say 2 to 6 months during radiation therapy, or is on it for 2 years, and then their testosterone comes back. Once the testosterone comes back and they don't have what we call an LH surge, which is the response to the absence of testosterone, their hot flashes will go away. And as I said, testosterone recovery is basically a function of the duration. So a patient that's on hormonal manipulation longer is going to have a longer time to recovery. So a patient that's been on hormones for 2 years, some patients may come back quickly, maybe a month. Some patients may take a year to come back if they're sicker, if they have more comorbidities, and that can be dosed. That can be checked by the provider. The testosterone can be checked at the blood level. And if your testosterone has come back to normal, biochemically, then you should not have any more hot flashes at all.
Another question is, we know all the side effects of testosterone clearly. Now, once your PSA is stable, once it's been that way for a while, can you actually give testosterone in gel or patches? Is that something that's been looked at to bring the level higher?
Okay, so a patient that has had prior treatment for local prostate cancer, i.e., they've had the local disease, they've had surgery, or they've had radiation, and they don't have recurrence, and those patients are no longer. So patients that had radiation would have a brief period of hormonal manipulation, or up to 2 to 3 years. Those patients, it has been shown in trials that they can receive testosterone treatment. If their testosterone, the main cutoff for most physicians in Canada is a level of 10 or less, and having symptoms, we could give those patients testosterone. However, a patient that was shown to have biochemical recurrence without metastases, that was put on hormonal manipulation, that was stopped, or a patient that is known to have metastatic disease, either to lymph nodes or to bone, those patients, that would be contraindicated to give them testosterone therapy, because the giving of that testosterone would suddenly reignite the production of more prostate cancer cells. That being said, there may be some patients that may ask for it, and it may be given by certain providers, but that would not be standard of care.
All right, one last question very quickly. When one of the patients wrote us and asked us, how do I know whether or not I have become hormone resistant? My PSA has increased, but very little. I went from 1.5 to 2. So should I be concerned? What kind of results should I be worried about?
So a patient that's on hormonal manipulation, they're on some type of injection, and their PSA is stable, and it goes from about 1.2 to 2. You would dose, and that would have already been asked, most likely you would dose their testosterone. Let's say, for instance, their testosterone was high, so it was above, classically used about 1.7, now we use 0.7, let's say it was 5. We know there's a problem with the way that patient is receiving testosterone. It's rare, but it can happen that certain patients that are getting the injection, it's not done properly. Maybe a problem with the angle that the injection is put in with certain agents. And then you would consider, is there a problem with delivery of the product? However, if the testosterone was blocked, as we say, so below about 0.7 or up to 1, 1.5, and the PSA is rising on 2 occasions or more, we would call that patient either castrate-resistant or hormone refractory. And that patient enters what we call a new clinical entity. So they're no longer responding overall to hormone manipulation. And usually what that means is that if you have, obviously if you have prostate cancer, you can have millions of cells in your body that actually contain the prostate cancer in it. Usually it's a couple of clones of cells that have suddenly become what we call autocrine, or they no longer require testosterone to produce more cells. They have escaped the loss of testosterone. That can now lead to more metastases. Classically, patients that had a PSA that was rising with a testosterone that was blocked, the median time to the apparition of metastases is about 9 months. And now, though, those patients, so that's a realm we call non-metastatic castrate-resistant prostate cancer. We know that now those patients, if we put them on new agents such as darolutamide or enzalutamide or apalutamide or abiraterone, we can increase the time to which they don't have metastases to about 3 years. So we can buy them about 2 years of time of no metastases. Which is a huge improvement because those patients now have a much better quality of life, obviously. And as well, what's interesting is a patient that was what we call CRPC 10, 15 years ago, their lifespan at that point, we would say is about 3 years, 2 to 3 years. We can now tell them that their lifespan is about 5 years. And that's the median. So there are patients that will live longer for various reasons. So some may live 7, 8 years. But we can really buy them about another 2 to 3 years of time with these new agents.
All right, that's excellent. I think we're going to end on this positive note. I think it's important that, those years that patients have with with this new hormone therapy, there's also clinical trials going on. I mean, the more time you buy, the more research is being done, and perhaps, there are going to be clinical trials open for you at some point in 2-3 years that are not actually ongoing as we speak right now. So to buy time, I find is an excellent positive message. I think the presentation was very good. The advice that you gave to patients on how to look after themselves once, when they know they're going to start a hormone therapy, and ask the right questions if they do have side effects, and get the help that they need, is also a very, very strong message. All in all, this really puts an end to this webinar. So just, before you actually go, before you exit, you can actually use the pop-up button that says continue and click on it, and then you can fill out our survey. We really want to know, what you have to say. And of course, your opinion is extremely important for us. Outstanding questions, but like I've said, we have very little. Most of them have been answered, but certainly we will do a follow-up with our nurses with these patients. Just so you know, we're not going to have a webinar in July and August. The next series of webinar will be a special series of 4 in September as part of the Prostate Cancer Awareness Month. So your next rendezvous with us actually begins on September 8th, same place, same time. And once again, a huge, huge thank you, Dr. Lewinshtein, for your precious time. It's extremely appreciated. I'm sure that, patients will come back, they will review this webinar to get familiar with it. So it was a very important one. So thank you again. And to all of you, well, thank you for being with us, and do have a fantastic summer. Thank you. This is Marie-Christine Beauchemin for Procure en Parle.